Okay, I think we can get started here today. Thanks everyone again for joining us. Today we will be hearing from Dr. Beth Cohen, who is professor of medicine at UCSF and a staff physician at the San Francisco VA Medical Center. Dr. Cohen completed her residency in internal medicine, as well as a fellowship in women's health and a master's degrees in clinical research here at UCSF. She has clinical research interest in improving health and quality of life of patients with post-traumatic stress disorder. She's particularly interested in how PTSD impacts heart disease risk and is the principal investigator of the Mind Your Heart study, which is a large prospective cohort study of veterans with and without PTSD. Dr. Cohen is exploring biological, behavioral, and psychosocial factors that increase cardiovascular disease risk in patients with PTSD. And she has over 100 peer-reviewed publications exploring numerous socioeconomic, behavioral, and other risk factors associated with cardiovascular disease. So I'm really excited to hear your talk today. A reminder, if anyone has any questions, please feel free to put them in the chat or raise your hand, and we can also have you ask your question in person. So thank you, Dr. Cohen.
Thanks so much for the introduction, and thank you so much for the invitation to be here to talk to you about the mind-heart connection and how psychological stress and trauma can be viewed as cardiovascular risk factors. So before I get started, I just want to acknowledge that for many, and really all of us, I think this is a time of, unfortunately, unprecedented psychological stress and trauma. We are now in year 2, starting year 3 of a global pandemic. Even though we think things may be settling down from that perspective, there's a lot of new unrest in the world. And so I think now more than ever, it's really important to consider how psychological stress and trauma affect not only our mental health, but our physical health. And with that in mind, this is just an overview of what I'll talk about today. I'll begin by talking about the evidence for stress and trauma as cardiovascular disease risk factors. I'll talk about the mechanisms through which stress and trauma can damage the heart. And then finally, I'll talk about how we should incorporate this information into how we care for patients. So first, before we get into some of the evidence, I just wanted to go over a few definitions because I'm going to be using a lot of terminology and talking about some concepts that can overlap. And these are the ideas of adversity, stress, trauma, and PTSD or post-traumatic stress disorder. And just some definitions of these, when we think about adversity, we're talking about really a state that someone's experiencing. So a state of difficulty, hardship, or challenge. So this might be someone who has stress from a financial situation, someone who's experiencing discrimination. This is related to, but a little bit distinct from stress, which is really a response to that adversity. So stress is the psychological and physiological change that occurs in response to a stimulus that's perceived as challenging and or harmful. And then trauma is also a little bit distinct. So traumatic events are those that involve such a severe threat that there might be danger to life or physical health. And so the technical definition would be a deeply distressing event that involves significant threat and feelings that are intense enough to have a long-lasting effect on functioning. And so there are many events that we might consider highly stressful. For example, losing a job or the breakup of a relationship, but they may not reach the level of threat that is necessary to qualify as a traumatic event. I don't say that to indicate that they're not important. And in fact, I'll be showing you that all of these impact cardiovascular health. But just to keep in mind, when we're talking about studies specifically of trauma, we're thinking about people who have witnessed or experienced these events that involve threat to life or well-being. And just a little bit of definition with PTSD. So post-traumatic stress disorder involves exposure to one of those events that can be considered traumatic, plus chronic long-lasting symptoms in each of 4 categories. So re-experiencing symptoms, this might mean someone having nightmares or flashbacks of the event. Avoidance, so maybe avoiding people, places, or things that remind them of the trauma, or just a general sense of emotional numbing. Negative cognitions and moods, such as blaming themselves for the trauma. And hyperarousal, which is a state of feeling on guard, or perhaps having reckless or impulsive behavior. So with that kind of terminology in mind, how common are these things? How common is stress? Well, the American Psychological Association has been doing an annual poll of US adults for many years that looks at stress levels and causes of stress. And this is some data from their poll from last year that found that the mean stress level in US adults, which is measured just on a scale of 1 to 10, showed that it had increased from 4.9 to 5.9. And interestingly, oh, thanks, Joyce. Is that better for sound? Okay. And interestingly, this is the first significant increase that they saw since they began studying this in 2007. And they found that, this is kind of a general level of stress, but there are certain populations that are experiencing even higher levels of stress. This is just one graphic from their report that showed stress related to the pandemic was particularly impactful for people who were parents. And they just released this month their 2022 poll, and I think we're hoping to see that with the pandemic being a little bit more stable, some of these stress levels might be waning. Unfortunately, 41% of US adults reported that they still have higher stress levels overall than they did pre-pandemic. And then they identified some new sources of stress. In the 2022 poll, 87% of adults said that they experienced stress from inflation, 81% endorsed stress from global uncertainty. So that's kind of measures of general stress. How about those more threatening traumatic events? Studies in US adults have found that the lifetime prevalence of trauma is 55%. So more than 1 in 2 people will experience a traumatic event throughout their lifetime. And of course, depending on the populations that we're working with, this might be even higher. Fortunately, not all of those patients go on to develop chronic symptoms of post-traumatic stress disorder. The prevalence of that in US adults is just under 7%. But again, this might be higher depending on our clinical population. So for example, the VA where I'm based, the prevalence of PTSD in veterans is between 10 and 30%. And it's estimated that currently there are 11 million adults in the US living with PTSD, and also that because of stigmas around reporting, it's possible this number is even higher. So what is the evidence for these psychological risk factors affecting cardiovascular disease health? So I'll talk about stress first, and this first figure is from a meta-analysis that looked at perceived stress and incident cardiovascular disease. And perceived stress is really a general measure, self-reported, where you typically ask people how much distress or stress are you experiencing. There's various scales, but it's a general measure of stress. And what you can see from this plot is that with the exception of one study, all of the studies found that increased levels of stress were associated with increased incident cardiovascular disease. And this involved nearly 120,000 patients, this meta-analysis. And the summary risk estimate showed that higher stress was associated with a 27% increased risk of cardiovascular disease. Now, this is a measure of general stress, but people have also looked at specific sources of stress as well. Michelle Albert, who of course runs the Nurture Center here, has done a lot of really profound work looking at the impact of racial discrimination on cardiovascular health. And work from her and others has found that people who experience discrimination have an elevated risk of cardiovascular risk factors as well as developing cardiovascular disease. There's been a lot of work specifically looking at job or employment stress, and a meta-analysis of those studies found that higher levels of job stress were associated with a 40% increased risk of cardiac disease. And kind of beyond these things that might be individual factors, people have looked at just the environment we live in. And there has been interesting work showing that people who live in neighborhoods with low socioeconomic environments are at increased risk of cardiovascular disease, and that's independent of, so after you adjust for their individual socioeconomic status. A lot of investigators have also tried to look at the impact of stress and stressful events throughout the life course. And this is a summary from one of the seminal studies in this area called the Adverse Childhood Experiences Study. And this is a study that interestingly was started by a physician who was working in a Kaiser obesity clinic and didn't have a particular interest in trauma, but noted that many of his patients were disclosing serious childhood abuse, and kind of wondered if there could be some connection between that abuse and obesity and other heart disease risk factors later in life. So was able to start this study, the ACES study, where they sent out a survey to over 17,000 Kaiser members in the San Diego area and invited them in for a full medical examination. And they sent them a questionnaire that asked about 10 different types of childhood adverse experiences. These included abuse, neglect, and household dysfunction. And they found that unfortunately these were quite common. So this is just the proportion of people, of respondents who endorsed each of these types of adverse experiences. So many endorsing abuse, neglect, and difficult circumstances within the family. So mental illness of a parent, divorce, separation, or substance abuse of a parent. And they were interested in looking at how these adverse childhood experiences could impact adult health. And so they've studied many health outcomes, but these are some of the cardiac outcomes they've studied. So this just looks at the prevalence in later life of diabetes, heart disease, and stroke. And what you can see is that this is more common for all of these in the people who reported having 4 or more adverse childhood experiences versus those in the blue who reported none. And they've gone on to look at these and also adjust these analyses for traditional cardiovascular disease risk factors, and have found that there is an independent association of the childhood experiences and cardiovascular risk. Because they followed this cohort for a long time, they've also been able to look at mortality and have found that childhood trauma has a very serious impact on life expectancy. When they looked at the people with the highest level of exposure, so 6 or more of those adverse experiences, they found that they died nearly 20 years earlier than those without any adverse childhood experience. So those are some studies looking at early life trauma. There are also many studies that have looked at just the lifetime influence of trauma and post-traumatic stress disorder. This is another meta-analysis slide looking at PTSD and incident cardiovascular disease in a very large group of patients, over 360,000. And similar to what I showed you for stress, you can see that the studies all have kind of different magnitudes of association, but they're all to this side of 1. So they're all showing an increased association with stress. And although each of these adjusted for different factors, all of them had some level of adjustment for sociodemographic variables and for traditional cardiovascular disease risk factors. And this meta-analysis was updated in 2018 with some new studies and had similar findings. And this is just the summary risk estimate. So PTSD was associated with an increased risk of 55% of incident CVD. One of the criticisms of some of the earlier work, particularly in PTSD, was a lot of the studies on the screen had been done in veteran populations, and particularly male veteran populations. But this work has now been expanded to many populations. So there has been work specifically in women veterans, the Nurses Health Study, which is also women, the Jackson Heart Study, World Trade Center cohort, studies of Holocaust survivors, refugees throughout the world, as well as survivors of natural disasters. And the findings are fairly consistent that PTSD is a risk factor, an independent risk factor, and has a level of magnitude of risk similar to what we associate with a lot of things that might be more front of mind for us when we think about cardiovascular risk, like smoking or high blood pressure. So some limitations, even though we've expanded to more populations, of course, we cannot randomize people to developing these conditions, experiencing these conditions. So all of this research is observational, whether it's from cohort studies or medical record studies, and therefore it's difficult for us to prove there's a causal relationship. Another limitation is that not all, but many of these studies used cardiovascular disease outcomes that were from self-report or were from diagnostic codes from electronic health records, and that of course can lead to misclassification. And there's also some concern for ascertainment bias. So we know from other studies that patients who've experienced trauma or PTSD or have higher stress levels tend to interact more with the medical system. So there has been a concern that perhaps these patients are just presenting more often, and so we're picking up disease more often or earlier in these populations. So to address some of that, people have tried to look not just at reports of cardiovascular disease, but actually at objective measures of cardiovascular health. And I'll talk through highlights from just a few of those studies. So this is looking again at early life adversity, and this is a study called the Young Thin Study, a cohort of over 2,000 children who were recruited in 1980. And they created a composite psychosocial stress score. So this combines stressors and traumatic events. So it looks at life events, parental behavior, socioeconomic status, and the emotional environment during childhood. And they followed the children in the cohort until they became adults. And when they were aged 24 to 39, they took carotid intermediate thickness measures as a surrogate marker for cardiovascular disease, and then repeated these 6 years later. And what they found were that the participants who had higher levels of adversity and stress had higher IMT, so indicating more atherosclerosis, and also a progression of that, because again, they were looking at over 2 time points. And similar to the studies of clinical cardiovascular disease I mentioned, they did adjust for cardiovascular risk factors, adult socioeconomic status, and depression, and found that the impact of this early life trauma went beyond some of those traditional cardiac risk factors. Another study that's looked at objective evidence is from Viola Vaccarino and her group at Emory, and they had a very interesting design. They used the Vietnam era twin registry, which is a cohort study of 261 Vietnam veteran twin pairs. And similar to others, they found that PTSD was associated with an increased risk of incident cardiovascular disease over time. But again, they wanted to look at some objective measures of cardiac health. And so they did PET imaging and found that the patients with PTSD also had evidence of reduced myocardial perfusion on PET. And they adjusted this for the standard risk factors as others have, but with this design, they're able to do something really unique. So they can look at twin pairs that are discordant for PTSD. So they can look at a twin who has PTSD and use the twin without PTSD as their own personal control. So that will control for shared genetic factors and childhood environment. And they found that when doing that, the association was still there. So this is not explained by traditional cardiac risk factors, genetic factors, or childhood environment. Or I should say not fully explained, maybe partially explained. And they followed this group over time. So they actually just this month released data from a 12-year follow-up visit on this cohort. And they found, they looked at low myocardial flow reserve, so a measure of microvascular coronary circulation, and found this kind of dose-response relationship between PTSD and myocardial flow reserve. So they found that this was low myocardial flow reserve was least common in the patients without PTSD, so only 40%. More common at 56% in the patients who had late onset PTSD. So these were people who did not have PTSD at baseline, but had it at follow-up, and was most common, 72%, in those with PTSD chronically, so over both time points. Because this was a longitudinal study, they were also able to look at change in MFR over time and found that there was a greater decline over time in those with PTSD. And similar to their prior study, this was not explained by traditional risk factors, comorbid depression, genetics, or childhood environment. So interestingly, this is a representation, you all would know this better than I would, of microvascular circulation, but they looked at other measures and found that, for example, looking at relative flow reserve, there was no difference. So they're doing more pathophysiological work in this area, but I think there is interest in whether or not this may be beyond just large arterial atherosclerosis and might be impairment of microvascular function as well. And this is an area that I've been interested in. So when I was a fellow, which was a long time ago, this was when some of those studies in male veterans had been published, but there wasn't a lot of information on mechanisms. There wasn't a lot of objective data. And so with my amazing mentor, Mary Hooley, I was able to recruit a prospective cohort of adult veterans called the Mind Your Heart study that we recruited between 2008 and 2010 from our local VAs here in San Francisco and Palo Alto. And we recruited 746 patients, over 250 of whom had current PTSD at the time we recruited them. And our goals were to evaluate the association of PTSD with existing and future cardiac events, and then also to try and get at some of these mechanisms that might link PTSD and CVD. So another thing I didn't mention with the limitations, but because it's very challenging to measure PTSD, it really takes a full clinical interview with someone who has specific training. Many studies did also rely on brief self-report questionnaires or on diagnoses from the electronic health record. we really wanted to dig into this and had some wonderful psychology collaborators. So we were able to do a gold standard interview for trauma and PTSD assessment. For cardiovascular disease assessment, we did exercise treadmill tests, and we did a full medical history and exam. And then we followed patients annually with telephone visits where we ask them about cardiovascular disease events. And then we get medical records for those and adjudicate them. And we also go through their VA and non-VA care records that we have access to look for events that might not have been reported. This is just a table showing our characteristics of patients without and with PTSD. We did recruit to age match the participants, and so our mean age at baseline was about 58 in both groups. Although we made great attempts to get women veterans in the study, and there was a lot of interest, particularly at that time women were just a smaller portion of the patients we were seeing. And it was particularly hard to find women veterans who didn't have PTSD, even people who thought they did not when we did the clinical interview often had subsyndromal or full clinical PTSD. And then this is a breakdown of racial and ethnic groups. It was a mostly white and Black sample. And we found that PTSD was associated with ischemia on the exercise treadmill test. So at baseline, ischemia was present in 10% of the patients without PTSD and 18% of the patients with PTSD. And I mentioned we've been following them over time. We're actually just about to start our year 14 follow-up interviews. And we have seen a number of cardiovascular events, and these have been more common in the patients with PTSD. So this is just showing the absolute composite event rate per 1,000 person years. And then when we adjust this for demographics and cardiovascular disease risk factors, we still see a 47% increased risk of cardiovascular disease events associated with PTSD. And just a breakdown of those event types, you can see what this is driven by. We also look at emergency room visits for chest pain. I didn't include that in this composite, but this is really driven mostly by differences in hospitalization for MI, revascularization, and angina. So I know that there was a lot of information. Just to summarize what we know from the evidence, there have been studies in multiple populations that have consistent findings that exposure to psychological stress and trauma increases risk for cardiovascular disease. And the effect, I think strikingly, is very similar in magnitude to things like smoking, diabetes, hypertension, that I think we talk a lot more and target more in treatment. And although some of those traditional risk factors haven't seemed to fully explain this association, they are important, and there is a lot of work being done to identify the mechanisms underlying this, which is really needed if we want to move from just defining this as a problem to working on prevention of cardiovascular disease and targeted treatments for patients with cardiovascular disease who may be experiencing high levels of stress or have a history of trauma. So I want to move on now to talk about some of those work with mechanisms. And I think it's really interesting to think about how we get from the brain, so our mental experience of stress and trauma, to damaging the heart. And many people have thought about this and looked at this, and I'm just going to kind of show you a big diagram of many of the mechanisms that have been proposed and that have some evidence, and I won't go into all of them today. But of course, there are the established risk factors, kind of the big five: smoking, hypertension, obesity, diabetes. And there is evidence showing patients who have higher levels of stress and exposure to trauma or PTSD have increased risk for these. As I've said before, we know that that doesn't explain the whole association with PTSD and heart disease, but it's clearly playing a role. But there have also been several other biologic mechanisms that have been proposed. We know that patients with PTSD have increased activity of the sympathetic nervous system, alterations in levels of stress hormones, and higher levels of inflammation. And all of those in turn can cause cardiovascular damage. They also have higher levels of some behavioral risk factors for cardiovascular disease. So there's a lot of work on PTSD and cardiovascular medication adherence, lower levels of physical activity, increased substance use, and impairments in sleep. And these are just, there are more, but these are some that have more evidence. And then none of these things occur in isolation. So someone who's experienced trauma is not going to just develop PTSD. They may also be dealing with depression. Patients may have issues with anger and hostility, lower levels of social support, lower levels of socioeconomic opportunity, and all of these things we know are risk factors for heart disease. But when we think about putting this all together, these are also things that probably interact in very complex ways. These risk factors can influence each other, they can directly cause cardiovascular damage, or they may lead to it through established risk factors. So it's probably going to be very complicated to put the puzzle all together, but we can identify some important areas that might be targets for treatment. And in terms of what I'll focus on today, I think how we address these established risk factors, behavioral factors, mental health factors is a little more straightforward. So I'm going to focus a little bit more on some of the data behind biological factors, and there's also been a lot of exciting new work in that area. So just to go through a little bit of the schematic, so getting from the brain to the heart, there are studies that have looked at brain activity in patients with high levels of stress or who've experienced trauma and found differences. And these differences in brain activity are in areas that can stimulate the hypothalamic pituitary axis as well as the sympathetic nervous system, which leads to the release of what we often term stress hormones, cortisol and catecholamines. And these can have direct effects on the heart, and I'll talk about some of those. And they also lead, very importantly, to activation of the immune system and the release of inflammatory cytokines. And of course, inflammation is a very important risk factor for the development of atherosclerotic plaque as well as plaque rupture. So one of, I think, the exciting things with more recent research is if I were giving this talk even 5, 10 years ago, I'd be telling you mostly about studies that looked at a little piece of this pathway. So I might tell you about a study that put patients with and without PTSD in an MRI and did a functional MRI study and found that fear centers in the brain lit up more in patients with PTSD. Or I might tell you about a study that took people who had experienced childhood trauma and measured IL-6 and CRP and found that they were higher in patients with PTSD or exposure to trauma. But now we have studies that are actually trying to connect all these dots within the same patients and follow them prospectively. And I'm going to tell you about one study in that area that I think is particularly interesting that's tried to kind of trace this pathway from the brain through inflammation to vascular disease and instant cardiovascular events. And this was a study that was led by Zahi Fayed, who's at Mount Sinai and Roger Pittman at Harvard. And they looked at about 300 patients who did not have cardiovascular disease or inflammatory disease at baseline and who had all undergone PET scans for various clinical indications. And these were whole body PET scans, and they looked at activity in several different areas. So looking at brain activity, they focused on the amygdala, which is the little tiny area that's in the picture here. And this is an area involved in emotional processing that's considered to be the fear center and can activate the SNS fight or flight response. And there's a lot of data showing that amygdala activity is abnormal in patients with PTSD. So that was the area they focused on for the brain. Then they also looked at uptake in bone marrow to see if there was indication of heightened activity of the immune system. And then they looked at inflammation on the arterial walls, hypothesizing that that would indicate arterial inflammation and potential for areas of plaque or plaque instability. So they looked at all of this, and then they also had were able to follow patients over time to look at instant cardiovascular disease events. And these are just some pictures kind of showing how they do these studies and what they found. So they found that baseline activity within the amygdala was associated with higher levels of bone marrow activity, so representing immune response, and higher levels of arterial wall inflammation. And this was also linked with instant cardiovascular disease events. So looking at the hazard ratio per standard deviation change in amygdala activity, that was associated with a 47% increased risk of instant cardiovascular disease. And when they just looked at extremes, so comparing people with what they considered high versus low amygdala activity, that was associated with nearly 5-fold increase in risk in CVD. And because they looked at all of this within the same population, they were able to run some statistical mediation models, which are trying to look at how much of this association that we're seeing between the brain activity and incident cardiovascular disease is going through that pathway of immune activation and arterial wall inflammation. And they showed that a good portion of it was at least statistically mediated through this pathway. Again, this is observational data. They're not able to manipulate the brain activity, manipulate the immune system, but I think it's the strongest type of evidence we can have to try and untangle how stress and trauma are affecting the heart and help guide us with where to go with therapeutics. And this is something I've been interested in looking at in my own work. As a young fellow, I did not have the funding to do PET scans on 700 people. Actually, at that time, I don't think we even had a PET scan here at the San Francisco VA. But we did have wonderful veteran participants who were incredibly generous with their time, gave us numerous tubes of blood that we used to measure inflammatory biomarkers. And they also went home and collected their urine for 24 hours so that we could measure levels of cortisol, norepinephrine, and epinephrine. So we can measure stress hormones with 24-hour urine. So this is looking at the association I showed you earlier between PTSD and ischemia. And after we kind of adjusted for what we considered sort of the kitchen sink of socio-demographics, traditional cardiac risk factors, and lifestyle behaviors and psychosocial measures that were associated with PTSD at baseline. And we found that even after including all of that, patients with PTSD had about twice the odds of ischemia. Then we added in our biomarkers of inflammation and stress hormones. And similar to other studies, it didn't explain everything, but we saw a drop in the association that was greater than when we had added in, many other things we thought would be important risk factors. So it does seem like these biologic changes are playing a role. And what I've been talking about are all ways that, over time, over years to decades, could accelerate the development of atherosclerosis and ischemic heart disease. But there is also a lot of interesting work about the acute cardiac effects of stress and trauma. So this idea that perhaps stress is not just an underlying risk factor in the development of chronic disease, but could also be an acute trigger for plaque rupture or an MI. We know that this cascade of things that happen when you expose someone to stress triggers increases in heart rate, increases in blood pressure, activates platelets, can in susceptible people trigger endothelial dysfunction or coronary vasospasm. So all of this could increase myocardial demand, causing ischemia, or potentially lead to plaque instability or rupture. And the group that I mentioned before at Emory that had done the myocardial imaging has also done a lot of work on the acute effects of mental stress. And they were interested in whether or not patients with PTSD might be more susceptible to triggering of cardiovascular problems from mental versus physical stress. So they took 300 patients who had a history of MI, and they did myocardial perfusion imaging under 3 conditions. So rest, and then with a mental stress task, which is a very common standardized stress task. It's actually a public speaking task. Apparently that's a universal stressor for people. So they ask them they give them, I think it's 5 minutes to prepare a talk on something they hand to them. And then they have to give a brief presentation in front of a bunch of research assistants dressed in lab coats and with a clipboard. And that is a very reproducible stressor. I think math tasks are another common stressor that they use. But just to emphasize, you can imagine how that might be a different type of stress from someone who is experiencing discriminatory stress or traumatic events. So all of these are proxies for what people may be experiencing in the real world. That was the mental stress task. And then lastly, they did a conventional stress test. So exercise if patients were able to, or pharmacologic stress if that was contraindicated. And what they found were that the patients with PTSD versus those without showed higher levels of having mental stress-induced ischemia, and they also showed more severe mental stress-induced ischemia. But interestingly, there was no difference in ischemia with the conventional exercise or pharmacologic stressors. So this made them think that there may be something in that cascade issue before with the brain reactivity that's causing some chronic changes and is priming these people to be more susceptible to mental stress-induced ischemia. So this could be an important mechanism for some of the incident and even recurrent events that we see in patients with trauma. So another kind of whirlwind tour, but to summarize what we know about mechanisms, traditional risk factors may be important, but they don't fully explain the association of stress and trauma with cardiovascular disease. And likely it's a complex, interconnected web of biological, behavioral, and psychosocial risk factors that are underlying this association. And we certainly need more longitudinal studies, but I think there's already a lot that we know. We know how to target many of these behavioral, psychosocial, and traditional risk factors. And what we're learning about the biological impact of stress and trauma can lead to new pathways for prevention. So how do we move on to that? What are some of the implications of this work for caring for our patients? If you think about that pathway, it takes probably quite some time for people to develop, going from having a stressful or traumatic event or experiencing these cumulatively throughout their life course to having increases in traditional cardiac risk factors or kind of the chronic accumulation of those mechanisms we were talking about, and then having that lead to clinical cardiovascular disease. So there are many points during this cycle that we could intervene. Certainly, I think prevention is very important. When we think about preventing or ameliorating the effects of stress or trauma, I think we're really talking about addressing huge underlying social inequities. And it's very exciting that I think this is actually getting discussed at high levels of government now. How do we address deep-seated social inequities? How do we provide better education, better support, better healthcare to all? So I think those are things that we need to advocate for as healthcare providers. Probably where we might feel like we have more of a direct and concrete role might be in screening and knowing which of our patients have high levels of stress or exposure to trauma. Once we've identified a patient as experiencing considerable amounts of stress or having a history of trauma, we can target treating stress, trauma, or post-traumatic stress disorder, and we can think about how we prevent cardiovascular risk factors or some of those downstream consequences of stress. And then, of course, we can also think about in patients we already know who've developed risk factors or who already have clinical cardiovascular disease, are there ways we can better engage them in the treatments that we know will help them? Or are there perhaps novel treatments that can incorporate some tailoring to patients with stress or trauma? So I want to talk first a little bit about screening. Just working in a medical setting means that we are going to encounter many people who've experienced trauma. I showed you that it's common in the general population, but it's enriched in medical settings. So studies that have looked at all comers to primary care clinics have found that 15 to 20% are currently experiencing a traumatic event. So remember, those are things more than just stressors, but things like interpersonal violence, chronic and severe illness. In the emergency room, this is even higher. Studies have shown 30 to 60%. And there have been studies that have looked at screening for stress and trauma in these environments. And it's been shown people often worry, well, is my patient going to want me to ask them about something so sensitive? Patients, especially if it's done in an appropriate way with a therapeutic alliance, actually tend to respond quite positively to providers trying to engage them to discussions around stress and trauma. And screening for stress and trauma has been shown to improve patient satisfactions and outcomes. Now, this has not been specifically studied within the cardiovascular setting, so I'm not suggesting that you start universally screening everyone who walks into cardiology clinic with stress and trauma. But I'm kind of curious if people can enter in the chat. I can think of a lot of barriers, but I'm curious, like, what comes to mind for you as a barrier to asking your patients about stress?
Feel free to put it in the chat, or
I have the chat open on another screen so you can see it. I'm available in clinic and bandwidth. Yes, and I think so. I'm an internist, so I work in a primary care clinic, and yes, I think that is universal for everyone. And also bandwidth to deal with the responses or knowing what resources are available. Yeah, I think these are kind of the universal things that come up. Alexa says, we hear about trauma from patients in cardiac rehab who've gone through the experience of serious medical illness. Absolutely. So I didn't talk about it because I was thinking more about the direction of PTSD leading to MI, but MI and serious cardiovascular illness absolutely are traumas that can involve that life threat and lead to PTSD. And lack of resources, so assisting with responses. And so these are very common barriers. I think I'm very lucky. I work within a system, particularly within the VA, that's invested in trauma screening and has invested in integration and supportive mental health services. So I'm in an environment where if I screen someone, they're positive for PTSD or I have concerns about their stress level, there's a mental health provider in my clinic whose door I can knock on to try and get the patient connected with care. So again, I feel like there probably is more work to be done to figure out within the field of cardiology, should we be screening these patients? How should we be screening them? But my hope is that more and more you will have, particularly with interconnected services and with electronic health records, you may know when a patient arrives at your door if they've been experiencing significant psychosocial stressors, if they have a history of PTSD, for example. So I wanted to highlight also, I think one of the barriers is, well, where do I start? How do I screen for stress? And I just wanted to show that there are some very simple measures that have evidence. So this little picture is something called a distress thermometer. So just a visual that could also be asked to patients, just like we asked about pain in a scale of 0 to 10. So this is a visual one that says circle the number that best describes how much distress you've been experiencing in the past week, including today. And there's been a lot of literature around this, particularly within cancer care, and studies have suggested that people who endorse something over a 4 be asked more questions about their stress levels. And they've used this within cancer clinics and shown that screening for stress with then some follow-up from providers led to decreased use of the emergency room and even decreased hospitalizations. So again, different population, but suggestive that this may be something that's feasible to deploy. This is a primary care-based post-traumatic stress disorder screen, and this is something that's actually used universally within VA primary care clinics. And it asks about 5 common symptoms of PTSD, but you can see it's relatively straightforward. It may be more than we feel we have time to do in a busy visit, but it's something that patients could do in a waiting room. For us, this is something that our LVN staff does as they're checking in patients, well, hopefully not as they're checking vital signs, but during that kind of pre-clinic time, and then we get the results of this to follow up with patients. And it's considered positive if they answer yes to 3 or more of these symptoms, and that's shown as sensitivity for detecting PTSD in 78%. And when we ask about stress and trauma, the studies that have shown that there is benefit, it's important to consider that it has to be asked in a non-judgmental way, and that we need to kind of give patients an understanding or rationale for why we're doing this and try and normalize it. So it doesn't just come out of the blue, but a good introduction might be because stress and traumatic experiences can affect health, we're asking all of our patients X, Y, Z. So that's just a little bit about screening and something to consider. Kind of on this continuum, I recognize that you may be seeing patients when they're already here, when they already have very high risk of cardiovascular disease or known cardiovascular disease. So I'll focus less on, how do you get your patients into mental health treatment, and a little more here, are there unique things we can do to tailor treatment to patients with cardiovascular disease and these comorbid psychological risk factors. And there have been many studies that have looked at psychological treatments in patients with existing cardiovascular disease. This is a meta-analysis specifically of randomized controlled trials of psychological interventions. And notably, they excluded studies that focused exclusively on looking at the impact on risk factors. So this is a little bit different than cardiac rehab that might be trying to get people to exercise or adhere to their meds. They were really just focused on let's address your stress levels or anxiety levels, et cetera. And they found 35 studies that qualified that involved over 10,000 patients. And they found that these did improve mental health outcomes, which is great. They improved stress, depression, and anxiety. They also showed a significant reduction in cardiovascular disease mortality, but there was no change in overall mortality, in rates of MI, or in rates of subsequent revascularization. So a bit of a mixed picture on cardiovascular disease outcomes. So some people have wondered if maybe just kind of targeting these general mental health things on their own is not enough. And if we could actually add this to the more focused work we already do on cardiovascular risk factor prevention. And so this is a study that tried to embed this mental health component within a cardiac rehab program. This was an RCT that was done in 151 patients with cardiovascular disease, and they were randomized to 12 weeks of traditional cardiac rehab plus or minus a stress management training intervention. And they followed patients for a mean of 3.2 years afterwards. Similar to the other studies, found that they had mental health improvements, so lower levels of stress and anxiety, but they also had fewer cardiovascular disease events, so 18% versus 33 for a hazard ratio of 0.49. So a small study, but perhaps suggesting that maybe if we take what we already know works for cardiovascular disease, but perhaps tailor it for patients who have levels of stress or trauma and address some of these mental health concerns, we could get even more benefit. And what about this? I've been showing you kind of information about sort of general stress, anxiety. What about specifically using evidence-based treatments for PTSD? So there are some very specific treatments, both pharmacologic and behavioral, that have been shown to be helpful in patients with PTSD. And this is a study that I worked on that was led by Jeff Scherer at St. Louis University. That was a chart review study of 5,000 VA patients who were being seen specifically in PTSD mental health specialty care. And what we did was we looked at whether or not clinically meaningful decreases in PTSD symptoms led to changes in cardiovascular risk factors, and found that those who had a clinically meaningful decrease in PTSD had decreases in incident hypertension, greater use of VA weight loss programs, greater success with tobacco cessation, but it was not associated with a change in incident CVD outcomes. Although in this population, I think there were only 125 who had incident CVD. So that's something that might have been a little bit underpowered. But Jeff is continuing this work, and I had a promisingly scored grant to do more detailed information looking at the impact of treatment on cardiovascular and metabolic. So still a lot of work that needs to be done, but I think there is increasing recognition about the importance of psychological health as a cardiovascular disease risk factor. This is a recent statement that came out from the AHA looking at the connection between psychological health and well-being and heart-body continuum. And the most recent revascularization guidelines, and I know the print is small, but they had a class 1 recommendation that in patients who have undergone revascularization and have symptoms of depression, anxiety, or stress, treatment with cognitive behavioral therapy, counseling, or pharmacologic intervention is beneficial to improve quality of life. And I would say there's evidence for some, maybe not all, cardiovascular health. So to summarize some of the implications for clinical care, there are simple screens that exist for stress and trauma. We don't really have enough information about how we should apply these in cardiac populations, but it's still, I think, something we should be alert to and be thinking about, because psychological interventions can improve mental health and some, though not all, cardiovascular outcomes. And probably with more study, we can improve all of them. So just to wrap up some take-home points, adversity, stress, and psychological trauma are unfortunately common. Many of our patients are experiencing this, whether we ask about it or not, and all can increase cardiovascular disease risk throughout the lifespan. And this is likely due to a combination of biological effects, changes in health behaviors, and comorbid psychosocial. Prevention is going to require large societal changes as well as local community efforts. But there are things we can do as providers. There are treatments that exist for mental health symptoms people experience, and there are treatments for many of these mechanisms that we've discussed that can lead to increased cardiovascular disease. So I think the hope is that through better screening, treatment, and just recognition of these as risk factors, we can reduce cardiovascular disease. So I want to thank my mentors and collaborators in this work, particularly Mary Cooley, Tom Nyland, Karen Seal, Shira McGinn, Eko Jonathan, Julian Graham, and Ann Woods, and all of our staff and participants at our study, and the funders of some of the work. And I'm happy to take any questions.
Thank you, Dr. Cohen. I think your sound at the end got a little bit quiet, but we heard the majority of it. So I wanted to open up for questions. Please feel free to either put them in the chat or ask your question. You can raise your hand and we can have you ask your question in person. One question that I had, I think that these studies are really interesting, but there's a unique difficulty in standardizing the exposure. And I was wondering, especially for future studies, it was interesting when you talked about the study where, you know, they did public speaking, because that's an instant stressor for most people, including myself. Are there studies that have specifically looked at comparing the those objective measures of stress and seeing how they may affect immediate, you know, effects on the cardiovascular system?
Yeah, thanks for pointing that out. And there are many types. I mentioned the most common ones, but there are several kind of types of stressors, and they are standardized, and they can try and capture different types of real world stress. And many of them have looked at acute cardiovascular effects. So some have looked at, there was the mental stress ischemia test that I showed you, but there are many that have looked at heart rate variability, vagal activation. There are some that have had people with a catheter in and continuously drawn blood and shown, you know, spikes in stress hormones, changes in platelet activation. So I didn't dive into all of that, but there are many studies that have looked at kind of those immediate effects. And I think the question is, you know, when we talk about particularly stressors or people with PTSD who are having constant traumatic reminders, you know, these may be things that are happening to them day in and day out. And so what is that cumulative effect of that, of those responses over time?
Thank you. Any other questions in the last few minutes? Well, thank you so much, Dr. Cohen, for joining us. This was a great talk. And thank you everyone for joining us as well. Next week, we'll have Dr. Chang talking about some advanced heart failure management.
Thanks so much for inviting me.